Today, morning session is presented by Dr. Sharif Hasan. He will present about central venous catheterization. Every day we are dealing with this issue. Sometimes very easy, sometimes very difficult. So it's better to learn something from Sharif.
Assalamu alaikum. Very warm welcome to the today's seminar. Today I am Dr. Mohammad Sharif Hasan, specialist cardiac anesthesia, with the permission of our chairperson, Dr. Prashant Kumar and Dr. Professor Mulu sir. I would like to start my session. Today my topic is central venous catheterization. This is very common and our daily to daily basis practice we are doing in our cardiac anesthesia. First of all, we'd like to start the indication. In general, central venous catheterization is indicated for central venous pressure monitoring, hemodynamic monitoring, volume resuscitation. Then this is the most important, administration of drugs likely to induce phlebitis, like the drugs like potassium, amidon, 3% sodium chloride. These are the all likely to induce the phlebitis. And in cardiac anesthesia, the most important indication is administration of multiple ionotropes at the same time. Then the indication is, in general, lack of peripheral access, repeated blood sampling, and parenteral feeding. Now, the choice of our vein is, there are a lot of veins, but main choice of veins are internal jugular vein, subclavian vein, external jugular vein, cephalic vein, and femoral vein. Then, in cardiac anesthesia, our choice is, our first priority is internal jugular vein. Why? This is because free of surgical site, as we have seen that this surgical site is free of anything like catheter. Sometimes in general ICU or in the ward, they use the subclavian vein, but in our cardiac surgery, we like to free of this site. So our first prefer is use internal jugular vein. Secondly, actual CVP can be measured from the internal jugular vein. It is anatomically very closer to the RA and it has no valves, so that we can measure actual CVP. This is a quote, a very famous writer, D.H. Lawrence. He was a famous writer. One of my teacher in our Faridpur Medical College, when he lectured us, he always told that the eyes don't see what the mind doesn't know. That's because আমরা যদি না জানি, anatomical knowledge যদি না থাকে, সেক্ষেত্রে আমাদের আইজও সেটা দেখে না. That's why I have discussed very short the surface marking on anatomy of internal jugular vein. This is the common or main triangles in our anterior neck. This is the digastric triangle, carotid triangle. This is subclavian triangle and occipital triangle. But in internal jugular vein, our importance is, this is the sternocleidomastoid clavicle triangle. This is our choice of venous puncture. It is formed by the lateral head of the medial head of the sternocleidomastoid. That is the sternal head, and the lateral head of sternocleidomastoid. This is the clavicular head, and the base is formed by the clavicle, and the apex is formed by the two head of the sternocleidomastoid muscle. This way, this triangle contains the internal jugular vein and the carotid artery, common carotid artery. We puncture at the apex. Previously, I have mentioned this is the apex and this is the excess site of puncture. So this is the puncture needle. Then I will discuss the technique. Instruments for catheterization. We all know that we need a dressing set, cutting set, and the must be catheter set. In our OT, we use this type of CV catheter. There is a puncture needle, the extension, the dilator, scalpel, the suture materials, the CV catheter, and the guide wire, and this is the dressing set. And we must have to be sterile position. Now there are some types of catheter according to duration. The short duration we use non-tunnel. This is the tunneled catheter. It is mainly used in dialysis. For dialysis, there are others like peripherally inserted and implantable ports. According to lumen, there are single lumen and multiple lumen. Among the multiple lumen, double, 3 lumen, and 4 lumen also found. Sorry, there is a hang in the computer. Another types is according to valve, open-ended. We use this open-ended catheter always, but in case of dialysis, they use closed-ended, that presence of valve. This is the closed-ended catheter. Technique of insertion, we usually use blind technique and the ultrasonoguide technique. In the most of the countries in the world, they are using nowadays the ultrasonoguide technique. This is the ultrasonoguide technique. In case of blind technique, the technique is right side preferred. It is due to the lower pleural dome and thoracic duct on left. Trendelenburg position is 10 to 15 degrees. Head rotated approximately 15 degrees to left. And at the cricoid level, while palpating the carotid pulse, introduce a needle into the apex of the sternocleidomastoid clavicular triangle I have mentioned earlier at a 30 to 40 degree angle to the skin. Aim the needle caudally towards the patient's ipsilateral needle. This is the Schildinger's technique. After puncturing and confirm that the vein is punctured, wire is threaded through the needle almost 15 centimeter up to the needle. Not more than that, due to there may be start of arrhythmia, cardiac arrhythmia. Then needle is removed. This needle is removed and the skin and vessels are dilated with the dilator by cutting the skin, small cutting the skin. Then catheter is removed here, and catheter is placed over the wire. After catheter is removed, the guide wire is removed, the catheter is secured in place. Then post-catheter placement, aspirate blood from the each port. We use usually 4 port. So 4 port must be aspirate blood and then flush with heparin saline. Secure catheter with suture, cover with sterile dressing, already mentioned. And lastly, obtain chest X-ray and or ultrasonogram. This is the catheter placement. We should finally can do this. This is a short, very short video about ultrasonoguided. This is the long axis guidance. this puncture has done. Then the all techniques are the other techniques are same. This is a very short video. Now, the disadvantage of internal jugular vein catheterization, there is a risk of carotid artery puncture and formation of large hematoma, and common is pneumothorax. This is pneumothorax is very common if we use the lower third of the triangle, sternocleidomastoid triangle. There are complications acute complication and the chronic complication. Acute complication is cardiac dysarrhythmia. As we see here in the monitor, we can see cardiac dysarrhythmia, hematoma formation, lost guide wire. This is very rare complication. Air embolism, another important complication, and the mechanical injury to nearby structures. Then chronic complication, there may be infection, blockage, thromboembolism, catheter fragmentation. This is the picture of infection in the catheter placement site. I have found two studies. Among one study is mechanical and infectious complication of central venous catheterization in a tertiary level in ICU, not in the cardiac ICU. It is studied in ICU in northern India. They have found that bleeding complications occurred more frequently with internal jugular vein insertion, and infectious complications occurred more commonly in cannula that were left in situ for longer than 7 days. This is very common. And another very important and study done in a British Journal of Anesthesia, mechanical complications after central venous catheterization in the ultrasonoguided. They have found, in conclusion, the incidence of major mechanical complications is low in hospital, where real-time ultrasound guidance is the standard of care for central venous access. So we should use ultrasound-guided central venous catheterization.